All right, well, I think maybe we'll get started just to make sure that we have a chance for discussion at the end. So good evening, everyone. For those of you who don't know me, I'm Jared Jensen, one of the PGY5s and chief residents here. And it's my great pleasure to kick off the chief residents grand rounds this year, talking a little bit about how man and machine may work together in human-centered AI and how that may help us to address some of our challenges in healthcare. I have no relevant financial disclosures. However, I am a glass half full technology optimist. And so I do aim for this talk to present a balanced view of AI in healthcare, but recognize that this is my bias as we talk about the topic here. So by the end of the hour, I hope to leave you with 3 key takeaways. The first is that human-centered AI will help us as physicians to process, interpret, and act on the expansive healthcare data in order to provide the best possible care for our patients and amplify our uniquely human abilities. Second, the AI hype cycle generates a lot of alluring headlines, but we really need to be able to critically appraise the clinical validation, the ethical considerations, and the last mile of implementation to really determine whether AI can succeed in healing healthcare. And third, physicians and surgeons, I believe, have a moral imperative to guide the responsible building of AI in healthcare. By attending to the needs of your patients in your practice, this will help guide us towards success. So in this hour, we'll lay the foundation first for why AI now, what is driving this real opportunity. Then we'll explore what does it mean to be human-centered AI and how that differs from how many others have talked about it. We'll then equip ourselves with the knowledge to critically evaluate the AI hype cycle. And then finally, we'll explore how AI may help to heal healthcare in the near and the longer terms. So let's get started by laying a foundation for our shared understanding. So it should surprise no one listening tonight that healthcare is in a bit of a crisis. We face an overload of new data and knowledge, and to date have really relied on increasing subspecialization in order to handle that growing complexity of care. Yet this also comes at a time when we face tremendous system pressures, increased expenditures without improved health outcomes, pervasive medical errors and waste, and decreasing face-to-face time, now really replaced by excess screen time. And so it's amidst these challenges that 3 key drivers have really propelled AI into the forefront of both public consciousness and research and industry activity. The first is the digitization of our workflows and the introduction of new digital data streams from biosensors and wearables. And this has really enabled the large volumes of data that are necessary to train AI models. Second, we need computing power that's at scale and an affordable cost to power that data processing. And this has really been enabled by cloud computing. And third, we need the introduction of a contemporary deep learning techniques that really came about in 2012. And this gave a significant boost to our algorithmic abilities to learn in complex data problems. So how does this AI boom then translate into our experience of healthcare as patients and as providers? Well, many have argued that AI may positively impact all elements of the quadruple aim as laid out by the Institute of Medicine. And I want to take a quick look at a few examples that are already out there in industry impacting these 4 areas. So in patient experience, Wobot is a type of digital therapeutic that's being developed by a team here at Stanford, and that invites people who are living with mental health conditions to have simulated supportive conversations with AI that's accessible anytime and anywhere they need it. In the area of outcomes and population health, there's the Loop artificial pancreas. This helps patients with type 1 diabetes achieve better blood glucose control, while also at the same time freeing them of the burden of constant finger pricks, carb counting, and the glycemic roller coaster. In the area of reducing costs, tools like Buoy and other similar companies have built healthcare triage tools. So when a patient has uncertainty about their symptoms, they don't go to Dr. Google and get lost in a chain ending up in telling you have cancer. Instead, they chat with an AI that helps answer their questions and then directs them to the most appropriate care setting. In work from Bowie, they showed a 40% reduction in ER visits and a 50% reduction in non-ER visits without any delays in necessary care. In the area of care team well-being, how do we as physicians, nurses, et cetera, benefit from AI? Well, many of you are familiar with Dragon Dictation, which helps streamline our documentation by transforming our speech into text. And this in turn helps us spend more time with our patients and also with our families. Now, maybe you're thinking right now, well, I understand Dragon. I just speak, it outputs my text. It's pretty simple. But what happens when AI is interpreting my radiology images or recommending the best chemotherapy for my patient with head and neck cancer? Would I trust it then? And I know that change isn't easy, especially when it impacts the way that we carry out our everyday lives. I want you to put your mind back to 2007, when the first iPhone was announced. At $499, most people wrote it off. They said, I have my Motorola Razr, my BlackBerry, I'm set. I don't need this thing. But of course, now with hindsight being 2020, we could never imagine a world without the iPhone and the many Android smartphones that came along after, and all of the new technology and abilities that they have enabled. The same evolution can also be seen in our field. In 1985, David Kennedy published his seminal papers describing functional endoscopic sinus surgery. And the field has really evolved to such great extent, driven by the key introduction of new technologies with the endoscope and micro-through-cutting instrumentation. So as we stand at this point in 2021, with AI just now starting to be used in clinical practice, I want to ask you, how do you all feel about bringing AI into healthcare? Maybe you're feeling optimistic, like the few early adopters of the first iPhone, but maybe you're more pessimistic and more eager to take a wait and see approach. So if I can ask you all to jump on your phones, your computers in front of you, there's a link there at the top of the slide you can go to online, or if you prefer via text message. Go ahead and share how you're feeling about AI in healthcare. We'll take a few minutes here for everyone to respond. This is great. I see new overlords. I think there's a lot of people who are worried about, AI and its ability to sort of control what doctors are able to do. A couple of people who are saying they're excited. That's probably the #1 word people are throwing out there. That's great. See someone who wrote that they're overwhelmed. Well, I hope that by the end of this hour, you'll feel a little less overwhelmed, armed with some good background and helpful ways to think about the problem. All right. Well, thank you all for sharing. And you've really encapsulated here, the full spectrum of how we feel as a community here at Stanford. And I think really are representative of the way that a lot of healthcare providers around the country are thinking about these issues. And so as AI is brought to bear in healthcare, I really think it's important that we honor and respect a lot of these issues that you're all bringing up. And I hope that by the end of this hour, maybe some of these questions and concerns will have a little bit more grounding and how to think about them moving forward. So I'd like to take a moment here to share how I feel about AI in healthcare. I believe that human-centered AI can restore humanity to the practice of medicine. By freeing physicians from rote tasks, AI restores time for empathic care that occurs between a doctor who listens and a patient who needs to be heard. And blended with AI's ability to augment our performance in diagnosis and treatment, I believe that AI can create space for compassion. And this could ultimately mean fewer burned out doctors, more empowered patients, cost savings to the healthcare system, and ultimately healing of our broken system. So through the rest of this talk, we'll talk about how some of these ideas may come to fruition. So I put out this idea of human-centered AI, and I do want to break down this a little bit further about how it is a slightly different idea from just saying plain artificial intelligence. So simply put, human-centered AI is about improving the human condition with machine smarts. So what does it mean if something is human-centered? So I'll bet that many of you I know, especially those who have participated in the biodesign program, are familiar with the term human-centered design, which was coined by the Palo Alto design consultancy IDEO, and is now really regarded as one of the most fundamental paradigm shifts in the way that people approach problem solving in organizations of all sizes and across all industries. So human-centered means to focus on the needs of humans, not simply designing a new technology, a new product, a new service, simply because it's possible. Human-centered means to embrace empathy and respect for your users, as well as for those indirectly touched by your solution. And human-centered also means to stay grounded in a holistic view of the human condition. We need to consider all aspects of how people work together and how they're going to work with AI to best optimize these solutions and also minimize burdens that we might create by introducing new AI solutions. So if we now cast a human-centered lens onto artificial intelligence, is it time to reconsider what AI means? I love this quote by Fei-Fei Li, who's one of the faculty here at Stanford and one of the founders of the Stanford Institute for Human-Centered Artificial Intelligence. A few years ago in the New York Times, she wrote, "Despite its name, there's nothing artificial about this technology. It is made by humans, intended to behave like humans, and affects humans. So if we wanted to play a positive role in tomorrow's world, it really must be guided by human concerns." So perhaps we should just discard the term artificial, but then what do we replace it with? Perhaps it's augmented intelligence. In the IEEE, they said that augmented intelligence represents a symbiotic relationship between man and machine. Rather than replacing us, augmented intelligence helps heighten our decision-making ability, and by extension, our intelligence too.
Jared, you got muted accidentally.
Oh, thank you, Dr. Sun. So this term comes from 1956 in a book titled Introduction to Cybernetics. And augmented intelligence is actually also the preferred term of the American Medical Association. One other term I want to throw out there for consideration is adaptive intelligence. Henk van Houten, who's the Chief Technology Officer of Philips, wrote that any AI-enabled solution should be designed as a natural and helpful extension for people, just like a car navigation system that supports you in finding the best route to your destination. So we'll explore a little bit more about that in a moment. So if we put all of these concepts together and we say, what does it mean to have human-centered AI in healthcare? I find it helpful to think about it as a collection of tools for improving health by the alliance of man and machine. As I laid out earlier in one of the key takeaways, human-centered AI will help us to process, interpret, and act on the expanse of healthcare data. That's its tool. And the goal of that alliance is to provide the best possible care for our patients and amplify our uniquely human abilities. Healthcare AI, I believe, will allow computers to excel at what they are best at, making sense of complex data, providing answers, and doing so regardless of a human's cognitive bias, their fatigue, or their distraction. And this will free healthcare providers to renew our commitment to empathic relationships with our patients, serving as teachers and guides through the unpredictable experience of healthcare. So I'd like to introduce you briefly here to a case study that's really one of the best examples I have seen of human-centered AI. So a few years ago, Google Health's team saw a need to identify patients with diabetic retinopathy early in the disease course, when its trajectory can be intervened upon to prevent blindness. However, in low resource settings across the globe, screening diabetic patients is a massive challenge with incredible demand and limited availability of ophthalmologists. So they thought AI deployed in this setting could scale these limited resources and address a significant need. I'm going to come back to this case study here in a few minutes. But with that in mind, I want to define a few more of what I think are some of the shared principles and values that really underpin human-centered AI in healthcare. The first is that we should design AI solutions around people's needs, not around what's technologically possible. And this is how we ensure that the tools that we're developing really have the most positive impact on human health. In order to integrate into the complexities of healthcare and everyday life, AI needs to be adaptable to meet the unique situations of each user. As we invite AI into being a decision maker with us and our sacred bond between patients and providers, we must develop a trust between AI, the provider, and the patient. To do this, AI needs to prioritize patient privacy, safeguard data and algorithmic security, minimize bias, and strive for equity in all of its use cases. And lastly, human-centered AI is about having humans in the loop. I know someone mentioned earlier about being wary of the AI overlords. I really believe that AI needs to be there to augment, not replace healthcare providers. And AI users need to be partners with engineers across the entire process of building, validating, and deploying AI in healthcare to ensure that our collective work results in solutions that are feasible, sustainable, and effective. Now, to pursue these principles requires a multidisciplinary collaboration across many disciplines. And patients, of course, always remain involved at the center of our work. This collaboration requires industry and academia to be partners, not enemies. And it requires leaders who are unafraid to wear many hats and who are equipped with the skills to translate across disciplines. Now, I know this is hard work, and yet each and every one of us listening tonight can be a key contributor to this process. I want to take a quick moment here to call out some outstanding work that's already being done at Stanford. There's the Stanford Institute for Human-Centered Artificial Intelligence, which is working on the technology-adjacent societal challenges of bringing AI to fruition. There's the Healthcare AI Applied Research Team, or HART, which is working to bring real-world clinical validation to AI systems here at Stanford. And lastly, the Stanford Center for AI in Medicine and Imaging, which is a world leader in advancing research in computer vision AI and helping to educate folks across Stanford and across the world. So with this foundational understanding of human-centered AI in healthcare, in this section, we'll cast a critical eye on the AI hype cycle. As healthcare providers and ultimately users of AI, I really believe that we have a moral imperative to be able to interpret not only the headlines, but also the primary literature, and to decide whether an AI solution is ready for our clinical use. And I would submit to you that this imperative is no different than our role evaluating a surgical device, a surgical technique, or a medication. And this topic could easily be over an hour by itself, so we'll stick to a high-level discussion, and then I'll provide some more resources after my presentation for further self-directed learning. So one of the most infamous examples of the AI hype cycle is IBM Watson. Not long after Watson was crowned Jeopardy champion in 2011, besting Ken Jennings and Brad Rutter, if you remember, IBM charted a course to put Watson smarts to work in healthcare. By 2014, they had formed partnerships with Memorial Sloan Kettering and MD Anderson, working on personalized medicine for oncology. They talked about things like identifying clinical trials opportunities, suggesting optimal chemotherapy regimens, and learning not only from the expanse of medical literature, but also the health records of other patients. And the idea was full of hype, and while well-meaning, ultimately led to both institutions spending tens of millions of dollars without much to show for this time, expense, and effort. But I want to be very clear that we should not take from this case, excuse me, an ultimatum that AI cannot help in oncology. Instead, I think it's evidence of what we already knew, that healthcare is messy and complex and involves so much more than data alone. Watson and other efforts may eventually help solve these challenges. And in fact, the VA currently uses a Watson AI product to analyze tumor genomes and screen for mutations that may be responsive to existing FDA-approved drugs or clinical trial agents. It's a small step, but it's a massive help for time-strapped oncologists. Now, with the next few slides here, I'm going to get a little bit technical, but I think it's really essential for us to have a shared understanding for the rest of this conversation. So when we say artificial intelligence, this is actually a very broad term that refers to any of a range of techniques that allow computers to mimic human intelligence. Machine learning is a subset of AI that focuses on algorithmic techniques that help a system to improve by learning from training data and experience. And then deep learning is a subset of machine learning, where the system learns complex tasks by using multi-layered neural networks. These were developed as a way to simulate the activity of neurons in the human brain. I do want to clarify this distinction between machine learning broadly and deep learning specifically a little bit further. In both situations, you start with the same input and you get the same output. In this case, an illustration of a car. The difference lies in how the algorithm moves from input to output. In machine learning, a human, sometimes with the assistance of an algorithm, decides which features of the data, such as say the color, the shape, the wheel number, are important, and also develops a classification process to then map those features to an output. Deep learning, on the other hand, allows the algorithm to learn independently about how to get from input to output by processing the data through a neural network. And what the algorithm deems important is, in fact, often opaque to the user. And this is the so-called black box of AI. One last term from the AI alphabet soup to throw out at you, and that is NLP, or natural language processing. And this refers to AI that can understand human language, both reading and writing. Deep learning in recent years has significantly enhanced the performance of these tools, and this is what underpins things like dragon dictation. So now that we have a framework to understand at a very high level what AI does, we need to talk about data. It's really been said that data is the key for high-performing AI. And this has marked a challenge for healthcare because data is locked away in institutional silos, if it's even collected and cataloged in the first place. So when we assess data in an AI system, we need to consider two big picture concepts. The first is garbage in, garbage out. Data quality is essential. If the data is messy, frequently missing or unorganized, it's very difficult to create successful AI. But on the other hand, garbage in, garbage out also means that if you train AI with pristine data, it's also unlikely to work when applied to real-world data that's not as pristine. And similarly, labeling of the training data is also essential, and the quality of that labeling directly impacts the performance of the resulting AI model. Second, data volume and variety is proportional to model quality. In general, the more data and the more variety you provide to train AI, the higher quality model you'll obtain. You'll see in the literature a lot of examples of training AI on small data sets, and this can give you falsely promising results with a model that can't generalize when you actually apply it to new data that it hasn't seen before. So after an AI model is trained on data, we have to validate its performance relative to some benchmark. So to better understand this process, I want to contrast it with something that we're all familiar with, and that's the testing and validation of biomedical research, first with ex vivo and in vitro study, followed by in vivo. In AI, we call the initial stage in silico or synthetic. Here, we use a validation data set, often a subset of the full retrospective data, to evaluate the AI model relative to the humans who labeled the data. It's important to note that if the labeling is inaccurate or prone to subjective variability, for example, say the Gerbis scale, then our performance assessment can be skewed. Most AI validation is currently in this stage. In the second stage of validation, the model has to be tested prospectively in the clinical workflow to assess whether its performance remains up to par, and also, most importantly, whether it leads to the desired outcomes. Now, the real-world validation and ultimately deployment of AI requires that we tackle the last mile challenges of implementation. We really should not forget how big of a task this is. Experience from the business literature has taught us that in most successful AI projects, over half of time and financial resources will be dedicated just to implementation. And Hank Van Houten, as you remember from Philips, said that the hardest part is not the technology itself. The hardest part is getting that technology to work in a way that's accepted, trusted, and embraced by people. Now, as I alluded to earlier, if we follow human-centered AI principles, we will have already addressed many of these implementation questions. But as anyone who's worked on QI projects in healthcare knows, working with humans is often unpredictable and requires dedicated feedback loops with stakeholders to support effective change. Implementing AI works best if the AI is adaptable and tailored to support the patients and healthcare providers for whom it's working. And ultimately, it has to help nudge them toward the desired behavior change. Now, any new technology in healthcare could raise ethical concerns. But AI, as an independent decision maker that's informed by data, raises a number of new ethical questions that we as physicians and AI users need to be attuned to. So I want to put this clinical scenario to you for consideration to help think through some of these ethical quandaries. So Richard is a 56-year-old African-American man who comes to see you. You're a solo practitioner, comprehensive otolaryngologist, working in a small town, 3 hours drive from the nearest tertiary care center. He was referred by his dentist who noticed leukoplakia on his left buccal mucosa. On your exam, you're concerned that this might be cancer, and you decide to use your new AI lesion analysis tool, taking a photo with your phone and uploading it to the cloud system for processing. The AI outputs a 90% likelihood that Richard's leukoplakia is benign. He asks you if he should still be worried, and you reassure him that the AI must be right, but you're not really sure why. Now he returns to your clinic 6 months later with what's now clearly a T2N1 buccal squamous cell carcinoma. So the first issue here is patient privacy and confidentiality. We're very familiar as healthcare providers about how much we try to safeguard these aspects for our patients. But our historical rules of what constitutes privacy and confidentiality really don't apply in the AI universe. All data, including clinic notes and imaging, are generally thought to be fair game for use in AI training once de-identified. However, there's broad adoption of now re-identification techniques that are driven by AI that show us that perhaps our de-identification isn't good enough. And also, a patient can't opt out of sharing their data with the AI system if they want to benefit from its output. Now, just as connected medical devices have been found to be vulnerable to malicious attack, so too are AI systems. Both the data that underpins them and the algorithms once prepared are always vulnerable to malicious actors who want to take them down. And so how will we secure these systems and ensure that they perform as intended are key questions moving forward. AI is often said to be objective, but it's not free of bias. Remember that the system only knows what data it's supplied. So if our data sources are biased, so too will the AI be biased. And that may in turn propagate more biases in our healthcare delivery system. Users of AI are prone to either follow the AI output completely or reject it wholesale. Unfortunately, both these situations forgo the benefits of the man and machine partnership and introduce risks for error in the AI system's use. And lastly, healthcare providers have been taught that they should be able to explain how things work, from pathophysiology to pharmacology to interventions. But AI, and in particular deep learning, often cannot explain how it arrived at the output it did. We have to be able to accept this unknown and learn how to talk about it with other providers and our patients. And then the last point here is about liability for error. What happens when an error in patient care occurs because an AI system was used? Who do we attribute liability to? Is it the company who developed the AI solution? Is it the provider? This is often referred to as the many hands problem and will really require a lot of regulatory clarity and likely be subject to a lot of litigation. So I want to return to that landmark case study I mentioned earlier about the team from Google who set out to diagnose diabetic retinopathy on fundus imaging. And I want to use this to then apply our critical appraisal. So first, does the AI solution address an unmet need? Well, yes. As I mentioned before, there's a shortage of ophthalmologists to review retinal fundus photographs to screen for diabetic retinopathy. And we know that if we can intervene early, its progression is preventable. Is the data source in this study of sufficient volume and representative of the target population in which the AI model will be used? Yes. In this situation, the team collected 128,000 images from eye hospitals and clinics in India, as well as in rural locations across the US. And images were obtained with a variety of devices. The population was thus diverse, but also representative of the target use, which is low resource settings. Third, was data labeling and training performed with accepted reference standards and by subject matter experts? So I talked earlier about how important that labeling is. In this case, the study used international consensus criteria for diabetic retinopathy to grade these images. And secondarily, the grading was performed by 54 ophthalmologists. And notably, each image was graded by multiple ophthalmologists to prevent a single ophthalmologist from biasing the AI. And then fourth, how does in silico performance in this study compare with the reference standard? So as I highlighted here in red, in this study, they achieved 97% sensitivity and 93% specificity with their model. In contrast with the ophthalmologists who are their reference standard, they achieved 89% sensitivity and 86% specificity. So this AI model, at least in silico, performed a lot better than ophthalmologists. So the team moved on to assess how the AI and ophthalmologists could work together. They asked, does the assistance of AI improve human performance? In this case, yes. With AI assistance, general ophthalmologists achieved the performance of unaided retina specialists, while when they had aided retina specialists, they performed even better than the unaided group, showing that even someone who is at the peak of their field can still get better with the assistance of AI. Two, does the AI system lead to user automation bias? In some systems that might be true, but not here. When they stratified the data by whether the model predicted correctly or incorrectly, human performance improved when the model was correct, meaning that the model helped the human get better. But the human performance was no worse when the model was incorrect. So we think in this case that the user was not subject to automation bias. And then how does the explainability of the AI system impact decision-making? So in this study, they were actually able to unwrap that black box of the AI algorithm and turn it into a heat map that showed the ophthalmologist who was grading the images areas that the algorithm thought might represent diabetic retinopathy. And in this case, it had mixed effects. In patients who had diabetic retinopathy, the heat map improved the human's performance by helping them catch areas in the image that they may have missed. However, in patients without diabetic retinopathy, the heat map actually caused humans to overdiagnose and to give patients a higher grade than they actually deserved. So then they deployed the AI system in practice, and they tested this in a nationwide screening program in Thailand. And so we can ask, does this real-world trial effectively assess the AI model's generalizability and robustness? And I would argue yes. The images in this study were collected in Thailand, where you have a totally different population than the AI model was trained on. And it also had different workflows, different imaging systems, and this, again, confirmed that the AI performed well. And then how does this real-world performance compare with the reference standard? So really key in this study was that the reference standard was not ophthalmologists. It was the graders that already existed in Thailand's screening program, which were oftentimes nurses or other trained specialists. And so this provided a fair real-world comparison. For reference, the human performance of this group was 74% sensitivity and 98% specificity. The model achieved 97% sensitivity and 96% specificity. So much better than the human graders that were already in existence. And when we compare it to the in silico performance that I shared earlier, This real-world performance did even better. Now, this is likely due to additional AI enhancements that happened between the initial study and this one, but it reflects that AI can always be getting better. And the Google team also went on to share a little bit about the human-centered aspects of their work. So as in Thailand, as they put this algorithm into place, they reduced the turnaround time from patient check-in to a screening result from 10 weeks to 10 minutes. This alone is a substantial improvement for the patient and the care team experience, and it could lead to earlier interventions for patients with diabetic retinopathy. And in the process of making this work, they also reported a couple of key takeaways from that last mile of implementation. The first is that real-world workflow variability in exam settings led to variability in the quality of the captured fundus images, which in turn affected the real-world AI performance. So the team had to go back and ask, well, how can we optimize the capture of the images? So there was an educational component for the nurses who were capturing the images, figuring out how to better darken the exam rooms, sometimes putting hoods over the patient's head to minimize ambient light. They empowered nurses to review and partner with the AI, and by nurses being able to see the results of how the AI interpreted the images in real time, they were then able to provide real-time counseling to those patients. And this in turn led to nurses' pride in their work and a sense of fulfillment that they were actually making a difference. The third was that early stakeholder involvement led to identification of potential barriers in implementation. And this allowed time to design around these unanticipated complexities of care to best optimize the solution. So equipped with a set of core values toward what is human-centered AI, as well as a solid foundation to interpret these headlines and the research, I want us to now imagine the future. How will AI help heal healthcare? So over the next few slides, I'm going to share some examples from different aspects of applications of AI. And I want to be very clear, these are not exhaustive in any way, because that would be hours and hours of discussion in and of itself. So in radiology and radiation oncology, there has really been a wealth of digital data accumulated in PACS systems. And this has led to radiology really being a leader to date in AI development, both in research and commercialization. Within diagnostic radiology, there's momentum to help both with workflow and image analysis in both automated and assisted fashions. For procedural specialties like interventional radiology and even things like otolaryngology, use of ultrasound and other interventional techniques are being augmented by real-time AI assistance, both to help guide novice practitioners through complex or new procedures they're not familiar with, and in some cases, experienced practitioners just to help give them that extra edge. And AI has also been demonstrated to have broad application in helping to design radiotherapy more quickly and efficiently and more accurately. To highlight one example from our field is the use of AI to evaluate thyroid ultrasound. Many different classification schemes and ultrasound techniques have been employed to help differentiate benign from malignant nodules so that we optimize who gets a diagnostic FNA. But the experience with these systems shows that they don't really provide an ideal level of specificity. So in this work, the authors developed an AI system that performs with similar sensitivity to experienced ultrasound radiologists, so 85 to 95% sensitive, but much higher specificity, achieving 85 to 88% specificity versus a baseline of 57 to 68% for experienced radiologists. In pathology, this has really been a more recent AI player as slide digitization has become more common practice. And genetics has really had the advantage of digital data from the start, but they've been limited by the number of sequence samples that are available for analysis. So in pathology, AI has the potential to augment pathologists in some of their most challenging tasks, things like detection of lymph node micrometastases and distinguishing subtle findings on histopathology and cytology that might help to sway their diagnosis from one to another. In genetics, AI is already helping with tumor mutation and assessment, and then linking those results to personalized treatment options, as I spoke about earlier with the VA experience. It's also been showing promise in easing interpretation of genomic reports for both clinicians and patients. Computer vision is broadly about teaching a computer to interpret images, whether still or video. And radiology and pathology that we spoke about are specific application fields of computer vision. But it can also be applied to any form of endoscopy, microscopy, or wide field photographic imaging. And as a highly visual discipline, otolaryngology is really prime for computer vision applications. However, really key to capturing that potential is that we need to create concerted efforts around image capture, storage, and sharing across institutional silos. Here I've listed just a few examples of how it could be applied within otolaryngology. And I also want to acknowledge a couple of projects from our own department where our team has applied computer vision to tasks in head and neck oncology, otology, pediatric otolaryngology, and general surgical applications. While all of these are pilot studies, they do show the promise of computer vision across the breadth and depth of otolaryngology. Audio remains a significantly underutilized data source in clinical practice and AI applications. There's a lot of promise around streamlining clinic visit documentation with automated tools that listen in. There's been a partnership between Google and Stanford Family Practice to work on this. And additionally, as otolaryngologists, we're very familiar with diagnosing laryngeal pathology and Parkinson's disease by voice samples alone. But now we've really realized that we can do this on a broad scale with AI. And it's also been examined as a screening tool, taking those voice samples to potentially detect central neurologic diseases such as Alzheimer's, Parkinson's, and traumatic brain injury by screening these patients via telephone. AI has also been applied to mental health assessment by tracking features of patients' speech over time to monitor their response to therapy, as well as situations such as suicidal ideation. Perhaps the largest data source of all is the electronic health record. From fine-grained lab and vitals data to radiology reports, clinic notes, sociodemographic information, there is a wealth of data there. And AI is being used widely to mine the EHR for predictions about diagnosis and treatment. The example we spoke about earlier using IBM Watson in oncology is a perfect example of this. Additionally, we can use text mining to passively monitor patients at home, for example, by analyzing their tweets and Instagram posts for sentiments and clues about their mental health or dangerous home situations. Two studies I wanted to highlight here also come out of Stanford. The article on the left used hundreds of thousands of patient charts in the electronic health record to develop AI models that predict in-hospital mortality, unplanned readmission, prolonged length of stay, and discharge diagnoses. Notably, their accuracy was extremely high in all of these models and outperformed the standard prediction models using manually collected data points. The idea behind such a system is that it might allow for earlier interventions to prevent events and more accurately plan for hospital resource utilization. And more recently, our colleagues in radiation oncology and medical oncology used EHR data to predict survival time of patients with metastatic cancer. Interestingly, their AI system performed comparably with expert oncologists operating independently. But when the two teamed up, the augmented oncologist performed even better. And if validated, this could help us provide more accurate counseling to patients and guide discussions around goals of care. So for the sake of time, we obviously cannot review all of the amazing opportunities before us as we apply human-centered AI in healthcare. And if you want to hear about many more examples, I'll provide some more resources after the talk. So as these AI systems come to fruition and are validated, we will need mechanisms to regulate their deployment in clinical settings. And this is where the FDA comes in. Just last month, they published their action plan, outlining key steps that they're taking to address both the industry and health system concerns. To capture a few of these key points, the first is to provide a novel regulatory framework to address the complexities and the frequent changes that are inherent in AI software. Remember that the FDA has regulated medical devices and medications, which don't really change once they're deployed. But AI, by design and by necessity, should evolve with time. Second, the FDA wants to encourage industry best practices for human-centered AI development and validation. They want to support scientific development of methodologies that are used for the evaluation and the improvement of AI software. And they want to use real-world performance pilots to further clarify the distinction between pre-certification evidence and real-world evidence in order to decide what certifies AI efficacy as it is deployed in healthcare. So in this talk, I've highlighted how AI can benefit healthcare, and I've also shared some ethical considerations that we'll need to keep our eyes on. But what happens in the day-to-day when you're in clinic, you have a patient who is in front of you, and you need to talk with them about an AI system that you're using? Well, it really starts with you right here, right now, taking the time to learn the fundamentals of AI and how to critically evaluate any system you intend to use. But here are some additional thoughts that I think are really key. We need to validate our patients' fears and concerns. Just as we talked about at the beginning of this hour, you all have fears and concerns about how AI is going to be used in healthcare, and our patients do too. And those fears and concerns are based in real world concerns, and we need to validate and share that those are okay to have. And here is some additional information to help assuage those concerns. And so how can we do that? Well, we can share what roles you and the AI system will each play in the patient's care, emphasizing that you remain the captain of their care. This is an augmented system, it's not a replacement. Third, we can acknowledge the risks and potential benefits of the AI system, and when appropriate, provide literature support of its efficacy. So we're all familiar with the importance of informed consent with our patients. And so when AI is actively making decisions for us or significantly impacting the surgical care we're delivering, we need to talk about that as part of that informed consent process. And lastly, we need to be attuned to the potential biases and to the unknowns that exist in the AI system, and to share those with our patients. Just as we talk about the data from studies and whether or not they apply to a particular patient in front of us, we need to be able to do the same thing with AI systems. So in terms of leading the charge, as physicians and surgeons, I believe that we really have a critical role to play, leading the charge for human-centered AI to help heal healthcare. I believe, as I shared before, that we have a moral imperative to share our clinical expertise and our work environments with that entire big AI team. We know that there are many challenges ahead of us, and yet we also see the myriad opportunities before us that help us improve the care of our patients and our own work experiences. By collaborating with patients, designers, engineers, informaticians, and many others, as well as our commitment to being educated users and stewards of this new technology, we as physicians will help to give AI the shot that I think we all think it deserves. So at the end of this talk, if you had to put yourself here in one of these four categories, AI optimist or pessimist, and how willing and ready you are to integrate AI into your practice, I want you to go ahead and share with us now how you're feeling. Again, it's the same link or text code as we used earlier in the talk. So everyone, thanks for sharing. We have 9. I know there are more people on this call. All right. So right now we have a big group who are AI optimists and likely to integrate AI in their practice. And we also have a fair group who are AI pessimists, but are still at least open to experimenting with AI in your practice. And I think that no matter which of these groups you find yourself in right now, that's all reasonable. And I think that our goal here, and my goal at least for tonight, is to share with you some of the key things that we need to be thinking about and some of the optimism that at least I share and hope that you will all see as you continue to explore AI in the future. So to go back to a couple of the key takeaways that we talked about at the start of the hour. So when we think about human-centered AI, right, it's about helping us to process all of that healthcare data, to figure out what to do with it, because we as humans can't do enough with it alone. And really, it's about that partnership between man and machine, creating augmented intelligence that makes us better than we can be independently, creating space for compassion and empathy, things that only humans can really do. We've talked about, apologies. We have talked about how to appraise the headlines in the literature to really understand the AI hype cycle. And we've also thought about how we can ask the right questions when we're partners on the AI team. And third, I believe that we have a moral imperative as physicians and surgeons to guide the responsible building of AI in healthcare. Our engineering colleagues, they want us involved, and we have a responsibility to do so, because that is the only way that we will help guide AI to be successful for our patients. So I want to close with a quote. This is from an article in JAMA written by Abraham Verghese and a couple of his colleagues. He writes that human intelligence, working with artificial intelligence, creating a well-informed, empathetic clinician who is armed with good predictive tools and unburdened from clinical drudgery, can bring physicians closer to fulfilling Peabody's maxim that the secret of care is in caring for the patient. With that, I'd love to thank you all for your attention and most importantly, your participation during this talk. This has really been a fun opportunity for me to deep dive into a topic that I'm very passionate and excited about continuing to work on in my career. And I will send out some resources for self-study a little bit later this evening. So with that, I'd be happy to take any questions or comments that people have.
Jared, this is Dr. Koltai. Where is this going to be most effective in otolaryngology?
Yeah, I think that's a great question. I would say that we have a lot of opportunities today where we are underutilizing the data that's in front of us, and that's really where AI has the potential. So I think the early opportunities are in places like radiology and pathology. Things like being better at finding micrometastasis in our lymph nodes, so that we know how much radiation therapy we should be giving patients. Helping us as doing ultrasound techniques to be better at diagnosis and treatment there. But ultimately, I think that where we see the opportunities going are really limitless as we think about all of the data sources that come into play in our daily practice, and thinking about how we can be better diagnosticians and better able to provide good treatment for our patients.
So Jared, this is Achin. First, a quick comment and a question that may not be fair to ask. So as an AI engineer, also interested in its application in the healthcare, certainly I like the way you concluded about there needs to be a moral obligation for a collaboration between AI engineers and healthcare professionals to work together to develop the right kind of solution. And the question is, from the word cloud, I picked the two that came out here when you were doing the survey. Some folks are excited and some are sad. So there's no guarantee of success, but certainly you gave some very good examples of where we're seeing great success in terms of simplifying the processes and enabling the clinicians and doctors to do a better job. In some other areas, there might be failures, and we'll learn better to what not to do and where to improve. But all of that, whether it's enormous success or things that we learn and not to do, they're all exciting in my view. Where I'm trying to understand where there is sadness in it. Maybe you can share some insights from the healthcare industry ecosystem, where there might be sadness about it.
Yeah, that's a great point, Ashin. I think what I have heard from colleagues is that it really comes back to that term that somebody threw out there, the AI overlord. right? As physicians, we really pride ourselves on being independent practitioners, evidence-based for sure, but at the same time wanting to be able to practice and take care of that patient who's in front of us on a day-to-day basis. And there's a lot of concern about the way that AI may jeopardize that way of practice. And so I think that that really comes back to a lot of those human-centered principles that I spoke about before, of making sure that as we integrate AI into healthcare, we need to preserve that relationship between patients and providers, so that AI is there as seen as an aid and an assistant, not as something to be told to the doctor, hey, you better do whatever the AI tells you because the AI knows more than you. And so there is sort of this consequence of this knowledge battle and this fight for autonomy.
Understand. So it's mostly about the concern of us taking it the wrong way.
Yeah, yeah. And I think also about, administration of whether that's insurance companies or healthcare system administration, dictating patient care based on AI.
That raised a very good point. The insurance companies, as they always have in the past, will jump on this like a mouse on a piece of cheese. How do we prevent that from adversely affecting the patients?
Dr. Shago, I think that's an excellent question, and I don't know that I have a great answer to it right now.
So Jared, my perspective on this is very optimistic. I mean, if you think about what robotics and automation has done to industry, it takes away the drudgery of repetitive physical work. Ultimately, AI for the physician promises to take away repetitive intellectual work. So every time you take a history from the patient, this could be automated. You have a particular set of questions and answers that come back. The same thing with advice you give. And then you simply come in at the end, instead of running through a clinic saying the same speech over and over, you simply add value to what comes in. You talk with the patient, and the NLP, the natural language processing, listens and makes a note for you. So many of the things that stress and wear us out right now, potentially, if well iterated, could help us. The other thing is we spend a great deal of time in medicine stuffing our brains full of knowledge because we need to have it. On the other hand, if you have an AI-enhanced system that allows you to do the higher cognitive relationships rather than stuffing yourself full of knowledge and trivial pursuit because if you don't, you feel like you won't be serving your patients well. But the AI-enhanced systems can look at 6 or 7 different things that you've brought forward in history and exam and laboratories and suggest to you things that may be beyond the patterns that any of us would recognize, especially given our bandwidth within a given field and our lack of knowledge in rheumatology and in endocrine. It can bring it to us. So I'm very optimistic that AI enhancements will ultimately, after a transitional period of awkwardness, will be as natural as the things we take for granted today. We're no longer pen and paper. That's been a revolution, right? We're used to using Epic. Oh, it's clunky at times. It will get better. But AI can take away a lot of the drudgery that burns physicians out in the end of the day, if it's well done. So I'm an optimist.
Dr. Jacqueline, thank you for sharing those comments. And I think to piggyback on one point you made about this sort of knowledge relationship with humans and AI is that now we're seeing that trickle down into medical education, with a lot of people asking the question, well, should we completely change our model of how we train physicians if that is true, if that is the future of, an AI deals with a lot of the nuances of knowledge. How do we better train physicians to really integrate knowledge across disparate ideas and be able to be really critical thinkers, not just regurgitators of information?
Yeah, I mean, there was a wonderful McKinsey study that looked at the likelihood of various professions being replaced ultimately by AI-enhanced automated systems. And if you think about tax preparation, medical coding, these are things that don't have a great future. You look at image analysis, and you look at pathology and radiology, the practitioners gradually become QI overseers of what the computers are doing or resolving very difficult cases. But the AI systems improve over time. in that way. But in general, medicine and physicians and nurses are on the lower end of likelihood to be replaced in the workforce because of the lack of human empathy and the warmth of touch. It's not impossible for AI systems to simulate, and they may someday, but I think real warm human beings and are crucial to that relationship. So I don't think it's a great threat to the healthcare workforce. I think it's an extension of the healthcare workforce, but there are some fields you may not want your children to go into in the future because they will be obsoleted. Large segments of repetitive intellectual work that can be described by an algorithm will pass out of the economy. And businesses will save money. Insurance companies will save money by automating it.
Absolutely, couldn't agree
Yeah,
more.
Jared, it was an excellent talk, and I agree with all the comments, especially excellent comments by Rob. I think our field, otology in particular, is very adaptable to AI. You know, we look at the ear picture and then CT scan and then the audiogram patterns, and we make a decision how to treat the patient. And the computer can easily do this, probably even better than us, and can help us get a much better job. So I think the audiogram patterns, the CT patterns, these are so adaptable to AI. I mean, it's automatic. I mean, it's just like a shoe-in. So I think our field will be very much enhanced by AI, and I look forward to it. I'm very optimistic.
Yeah, in the end of the day, a field like surgery is of such high risk and requires teamwork and coordination across skill sets. So it's going to be one of the last things heavily impacted, I think, by AI, interestingly. But office-based practice, perhaps more so. So Jared, thank you so much for choosing this topic and for doing such a great job and stimulating us to think about the future.
Thank you all for your participation and your comments, and I really appreciate it, and be happy to talk more offline. And like I said, I'll send out some additional resources for those of you who want to dig more into some of this.